Chapter 59, Eye and Vision Disorders. These are some inflammation and infection of the eye that could affect the vision. You have blepharitis, hordeolum or stye, chalazion, conjunctivitis, keratitis, entropion and ectropion, foreign body, chemical spills and splashes, corneal opacity, and then we'll talk about nursing care and how we're going to manage this inflammation and infection. We learned from studying chapter 58 that the eyelids actually are lined with hair follicles and hairs. So blepharitis is the inflammation of the hair follicles along the eyelid. Signs and symptoms that we see with blepharitis is that the patient will have those itching and burning, and some of them will even have photophobia. Um, and they will have those scales and crusts in the eyelid margins. Usually, this dried crusts and scales, these are usually like more apparent upon awakening. Like, patient would sleep maybe at nighttime, and then when they wake up, it's more apparent when they try to like open their eyes, then they will actually see those dried crusts along the eyelid. It's usually caused by the Staphylococci bacteria. Okay, so now if it's caused by a bacteria, then that means we can use an antibiotic, right? But when we give antibiotic for blepharitis, we gotta make sure that the preparation of the medication is actually what we call ophthalmic preparation. Okay, ophthalmic meaning those ointments that we're gonna give is actually really meant for the eye. Some complications that we see if blepharitis is left untreated, it could lead to the formation of what we call hordeolum or the stye, or we could even have an inflammation of the inner structures of the eye, or from the cornea to the inner structures of the eye. Those are some of the complications that could happen if blepharitis is not being treated. Okay, hordeolum or stye. This one is when there's a hair follicle that is infected most of the time by a bacteria. Staphylococci bacteria is the most common cause for this type. So signs and symptoms would be the area would be red and then swollen and tender. Some of the management that we can do for stye or hordeolum is we can do like a warm compress, moist compress, because it helps with the inflammation itself. And then because there will be like pus in the area, we're gonna need to do an incision and drainage. We might need to do an incision and drainage, meaning they're gonna probably need to open it a little bit so that the area can be drained. All those pus will come out. And because it's caused by, or if it's caused by Staphylococci bacteria, then we can use ophthalmic antibiotic. Chelation. What is chelation? This is an inflammation of the glands in the eyelids. There is a swelling that preventing the fluid from leaving the glands, causing them to become enlarged and then tender. To manage, we can actually do some warm compress again to decrease the inflammation. Or if it gets really bad, then we might need to do some treatment That includes corticosteroid injection into the chelation area itself. Conjunctivitis is commonly called as the pink eye, and this one is the inflammation of the conjunctiva, and it may be caused by bacteria, viruses, allergic reactions, or chemical irritants. Characterized by the redness of the conjunctiva itself, there will be mild irritation, and there might be some drainage, purulent drainage. Some viral conjunctivitis, which could be caused by the herpes simplex virus type 1 or the zoster virus. When those viral infections are causing the conjunctivitis, we could tell because the drainage is a little bit is watery rather than purulent drainage. So how do we manage it? We can give them anti-inflammatory eye drops or some topical vasoconstrictors to kind of help with the inflammation. Warm or cool compress can also help. And again, if it's caused by virus like the HSV1 or the herpes zoster virus, then it is watery drainage and could also be longer than bacterial infections. But other organisms can actually cause conjunctivitis. It could be caused by the chlamydia or fungi, right? In these situations, we can actually give them some topical or some systemic antibiotics. And one thing to remember for conjunctivitis is that it is contagious. Okay, the infectious agent can be passed from one person to another. It's contagious. So what are we going to do? We're going to make sure that if the patient needs help, we're going to help them actually do or practice good hand washing or hand hygiene. And if the patient is actually able to do it themselves, then we can even educate them to practice good hand hygiene. Also, we should educate the patient, or we should make sure that the patient is avoiding to share washcloths or anything that they use from their eye, right? And then another person would actually use it. They have to avoid doing that. Okay, keratitis is inflammation or infection or both of the cornea. Sources of infection could be from bacteria, virus, and fungi. Keratitis, they do not usually have like drainage, but it's a little bit painful. Some medications that we could give, systemic antibiotics or injects directly into the conjunctiva, of course, if it's caused by bacteria. And we can even give them like topical corticosteroids to help them with the inflammation. And if it's caused by virus, of course, we can give them antivirals, which again does not cure it, but it actually slows down the replication of the virus. If it's caused by fungi, obviously we're going to give them an antifungal. Some of the things that we need to remember, those topical anesthetics to kind of like numb the area, they are not used because the patient might accidentally cause additional injury to the anesthetized cornea. Another thing to remember, ice pads are not used with keratitis because they provide a dark, damp environment for microorganisms to grow. Entropion and ectropion. Entropion condition is when the lower lid turns inward. And the problem there is, the eye is actually lined with eyelid, the hairs, right? Hair follicles in the eyelids. So if the lower lid is turning inward, then it's actually the eyelashes is actually rubbing against the eye. It's causing pain and maybe very itchy, right? Very uncomfortable, and then the patient will actually start, scratching the eye too much, which can actually cause the damage to the cornea and any other parts of the eye. How do we treat? We can do surgical correction, so that that lower lid is actually not turning inward. Ectropion is a condition in which the lower lid droops and turns outward. So what's going to be the problem there? If with the entropion, it's actually because the eyelash is touching the inner eye, and then that's why it's like uncomfortable and itchy, and they might be scratching. With the ectropion, the problem there is that the lower lid is actually drooping, and it's like more open, right? Because it's drooping and it turns outward. So the main problem here is that the eye is not closing completely. And when it's not closing completely, it's causing for the eye to become dry and irritated. And because of the dryness, then the eye is actually at high risk for being injured, right? Injury to the eye. So how can we treat this? Well, we can actually do like symptomatically, or we can even do surgically if it's really bad and it's actually causing those dryness and irritation of the eye. Foreign body can actually enter the eye sometimes, and when we experience this, we will actually have some irritation in the eye, and then it will be the patient will actually feel discomfort, right? And they will even have those blinking too much, and then might even have some tearing of the eye because it's very uncomfortable. So if there is a foreign body, then we actually can do this figure 59.1 in page 1171, which is what we call eversion of the eyelids. This is used for infection of the sclera and the conjunctiva. So what we do is we actually do hand hygiene first, right? You're gonna do hand hygiene first, and then you're gonna put on your gloves, and you're gonna ask the patient to look up while you're actually pulling the conjunctiva down. Most of the time, if it's not embedded in the eye, you are going to see that foreign actually just floating around in the eye, right? And what we do is we grab a sterile cotton swab, and we can actually kind of like scan through it and just swab it there. And then if the object is not embedded, it's gonna cling into that cotton swab, and you can remove it from the eye. Chemicals, spills, and splashes, we will talk about that in chapter 63. However, there's what we call eye irrigation. So if things like chemical spills and splashes actually happen, then the eye needs to be irrigated, okay, so that the chemical is actually not going to stay in the eye, and then it's not going to cause further structure damage. Okay, we also have corneal opacity, because remember, the cornea, right, it should be a clear, should be something that allows the light to enter the pupil. What happens is that sometimes the eye gets injured, and then it becomes scarred, right? There's scar tissue that's gonna form, and it will actually cause this opacity of the cornea. Okay, so treatment. We use phototherapeutic keratectomy, or the PTK, which uses an excimer laser to destroy the corneal abnormalities. If that doesn't work, then we can actually do some surgery, which is called keratoplasty. And what we do with keratoplasty is that the um, removal of the scarred cornea, the damaged cornea, and then replace it with a healthy cornea. It's called keratoplasty. Okay, nursing care. So keratoplasty is a surgery, as I have just mentioned, right? And if you want to see it, it's actually in 1172, and it's very clearly shown in here how they're gonna do it. Like your figure 59.2. So it's showing us that there's an opaque cornea, and we're actually going to remove it, and then the donor corneal graft is actually moved, and then the donor cornea is now in place, or transferred into the new eye. And then your figure 59.3, that is actually how a keratoplasty look like in real life. The appearance of the eye soon after keratoplasty is shown in figure A. And then if the cornea that we actually implanted is having some rejection, or the body is actually rejecting the cornea that we implanted, your letter B, it's going to look like the letter B, right? There's an acute corneal rejection. Nursing care. This is a surgery. So we are actually going to make sure that everything is prepared before the surgery, just like any other surgery that we've talked about before. You're going to make sure that you're getting the consent, that the patient actually understand what the procedure is going to be, what will be the risks and benefits of the surgery itself. And then for the post-surgery, the patient has an eye patch and a metal shield over the operative eye. Or what they do is they actually temporarily patch the eye. The idea is we want to actually, reduce the eye movement until the eye actually heals. Corticosteroid eye drops can be given to actually reduce the inflammation. And the corneal transplant do not require those medications that we give to the patient to actually decrease the immune system, like immunosuppressant therapy, to prevent tissue rejection. Usually we don't for keratoplasty. Errors of refraction. So now we're talking about those refraction where the light is actually passing through the cornea, and those aqueous humor and the lens and the vitreous humor to reach the retina. And refraction is bending of those light rays so that the light itself can focus on the retina. Any of those abnormalities for that is called errors of refraction. So you have some of this, it's in this PowerPoint. You have myopia, which is also known as the nearsightedness. And then you have your hyperopia, which is actually or commonly called as farsightedness. Obviously, from the word itself, right, myopia is nearsightedness. So these patients actually need for an object to actually be near them before they can actually clearly see them. And then for hyperopia, this is farsightedness, which is when the person can actually see clearly when the object is more distant versus when the object is actually close. They have difficulty in focusing on those close objects. How do we fix? Where they need glasses, right? And glasses are usually approximately needed every 2 years. And for your hyperopia, this one actually needs a convex. We call it convex corrective lenses so that we can correct those farsightedness. Astigmatism is the irregularities in the cornea or the lens. Again, if this astigmatism is actually bad and the vision is actually affected, vision is distorted, then we need to actually have those corrective lenses for the person. And just to let everyone know that astigmatism can actually be with combined with myopia, like astigmatism with myopia or astigmatism with hyperopia. Presbyopia is the inability to focus on near objects. The keyword for presbyopia is the inability to focus. It's the focusing, okay? We call it the accommodation, eye accommodation. Accommodation is the adjustment of the lens of the eye for like near and then distant vision, okay? So, how do we actually correct this? The primary treatment for errors of refraction is the prescription of corrective lenses. The patient will have eyeglasses or contact lenses. And for the eyeglasses, they might even have those bifocal lenses, which we call it bifocal because there's two different lenses. The upper part of the lens is used for like distant vision, and then the lower part is used for like near vision. And some glasses even have like trifocals. We call it has three lenses for distant, for closer, and for near vision. Okay, for surgical treatment for errors of refraction, we have what we call photorefractive keratectomy or PRK, which is a laser. It uses a laser to reshape the cornea. And then we also have the LASIK, which is a procedure that involves peeling back a thin layer of the cornea and using a laser to reshape the middle layer of the cornea. Nursing care. So we're going to educate our patient about the proper use of the contact lens and those corrective lenses like those glasses. Okay. Okay. Cataract. Cataract is when those clear lenses becomes opaque or becomes cloudy. And there are some types of cataract. There's like congenital cataracts, which are those that are present at birth. And then there's traumatic cataracts, which are caused by the damage from the chemical, um, mechanical, heat, or radiation injury. And then there's a degenerative cataracts, which is common with aging, but they can also occur with um, people in people with diabetes or Down syndrome. What are signs and symptoms of cataract? They will see spots, ghost images, and some of those floaters. Medical treatment, we can give them some of these medications or eye drops. We call it mediatrix. Mediatrix right here. And what it does, it kind of like open up the pupil of the eye, or it dilates it, um, and also relax the some of the muscles of the eye. And then we're gonna do surgery. right? What they're gonna do is, if you look at those figure 59.5 in page 1175, this is how a cataract extraction is being done. Okay, from A, intracapsular cataract extraction with removal of entire lens and capsule. B is extracapsular cataract extraction, leaving the posterior lens capsule intact. Okay. And then for complications, again, this is a surgery of the eye. So same thing with the pre-operative and post-operative nursing care. We're gonna do the same. However, some things to remember. When we do the surgery and the lens, which is the problem here, is been removed, then the eye is said to be aphakic, which is APHAKIC. You can see it also in page 1176 if you want to read more about it. Aphakic is when the patient is extra farsighted and is unable to accommodate for changes in object size. Okay, going back to the nursing care. So what are we gonna do for the pre-op and the post-op? Pre-op, there might be some eye drops that we actually need to give to the patient at frequent intervals. Common drops that are used before the cataract surgery are what we just talked about: mediatrix, psychoplegics, antibiotics, and some NSAIDs, which is for anti-inflammatory. For your psychoplegics, this one temporarily paralyze the muscles of accommodation, keeping the eye still during the procedure. Antibiotic can help us reduce the risk of infection, and then NSAIDs obviously is to reduce the inflammation. Then for post-op, we gotta make sure this is a surgery that we're asking for pain control, right? And because it's a surgery of the eye, so sometimes the patient may return to or from surgery wearing a patch and a shield over the eye that was operated on. So that actually putting at risk for injury because of that. So we gotta make sure that we are putting things in place to ensure the safety of the patient. Glaucoma is a condition in which the intraocular pressure is increased above normal. And this is one of the leading causes of blindness in the United States. So in a normal situation, what happens is that we learned about those aqueous humor that is actually in the anterior chamber of the eye, and usually it flows through, like it has to leave the anterior chamber of the eye to keep that intraocular pressure normal, which is 10 to 20 millimeter per mercury. With glaucoma, there is a problem with the outflow of that aqueous humor. And when there's a problem with that, then you're gonna have that increased pressure, increased intraocular pressure. Patients is going to have tunnel vision, blurred vision, some halos around the eyes, or some patient may even have just tired eyes, or some may even be asymptomatic. So we have two types of the glaucoma. One is open angle glaucoma, which is a chronic, okay, and then the other one is acute angle closure glaucoma. For chronic open angle glaucoma, this one results from some alteration that prevents the normal passage of aqueous humor through the trabecular meshwork, which is one of the part of the eye. Usually, no signs and symptoms appears at first for the chronic. Um, it's just those mild blurred vision, halos around the lights, and then the angle closure glaucoma is acute glaucoma. With this one, the flow of the aqueous humor through the pupil is blocked. The pressure forces the iris forward, causing it to block the trabecular meshwork. And then there is a rapid rise for this one of the intraocular pressure. Rapid rise that is greater than 50, okay, 50 millimeter of mercury. And very important for us to address right away for the acute angle closure glaucoma is that the pressure needs to be lowered right away because permanent blindness can result. For this one, in addition to the blurred visions and the halos around the lights, some patients may even have nausea and vomiting and even headache on the affected side of the glaucoma. So, medical treatment. The goal is to reduce, of course, the intraocular pressure. Okay, we can give them those medications like beta adrenergic blockers, adrenergics, cholinergics, carbonic anhydrase inhibitors, and hyperosmotic agents. The drug therapy box in table 59.1 in page 1180 is very helpful. The drug names are there, the use and the action of the medication, the side effect of the medication, and what nursing intervention are we supposed to do for the patient when they are taking these medications. For nursing care, like we said, we have to be um, very mindful of the signs and symptoms of the glaucoma, especially the acute angle closure glaucoma, because that is an emergency situation that we actually have to address right away. Retinal detachment is when there is actually the separation of the layer of the eyeball that is actually responsible for the sensory layer of the eyeball from the other layer, the pigmented layer. This could be spontaneously, meaning, it's like little by little, right? And it's progressive. Or it could be resulted from a trauma. Maybe the patient just had a fall, bumped their eye somewhere else, right? Or a patient just had an altercation, or all of those things that actually could result trauma. Some of the tears um, could actually be corrected by itself. But if when it's really bad, then that's when we're gonna need those medical and surgical intervention. Signs and symptoms, please look at 1182, figure 59.6. That is what it looks like. You see how that is a detached retina is actually seeing. It's like there is like a curtain, is what we call it. There's like a curtain over the vision itself. Or if it gets really bad, the detachment is really, large, then the vision actually may be lost completely. Okay. um Treatment. Look at page 1182, that figure 59.7. So those are actually, so the letter A is the retinal detachment itself, and B and C is how we try to actually correct the situation. The first one is you're gonna see that there's like a silicone implant and there's like a band, right, that is actually encircling the um, eye. And then the other one is when there's a band, there's an implant over the retinal tear. Senile macular degeneration is when there's changes in the eye that cause the macula to actually degenerate. Usually both eyes are affected. And what is macula? Macula is the part of the retina that is responsible for the central vision. Okay, central vision. That is why, if you look at page 1183, figure 59.8, that is how it looks like. That's a vision of a patient with macular degeneration, because again, like we said, macula is the one that's responsible for the central vision. And you see how that vision in the middle, right, in the central part of the vision is actually affected. Okay, there's two types. There's dry or stereotropic, or there's wet or exudative. The dry one, senile macular degeneration, is when the central vision is gradually getting worse. So how does it start? Usually patient will tell us they are having difficulty reading or doing some close work. The wet type of this is when there's an abnormal blood vessels that is actually developing in or near the macula that results this loss of vision in specific area. Special lenses can actually be helpful, or some laser treatments and intraocular injections with an angiogenesis inhibitor can actually help some patients. Nurse needs to help the patient and family members to learn to cope with the declining of the vision. Inoculation is the removal of the eyeball. Sometimes when the infection or the inflammation gets too bad, from maybe injury, from infection, from glaucomas, from whatever malignancies it is, then we remove the eyeball, and it's called inoculation. In page 1184, figure 59.9, the picture is actually showing us on the proper process of removal and insertion of an eye prosthesis. So um, again, sometimes it gets too bad that the patient actually might have an eye prosthesis, and this is actually how we're going to help them care for their eye prosthesis. Okay. Post-operative for inoculation is to observe for excessive bleeding or increasing pain. This is a surgery, so we're gonna make sure that we're monitoring them for those bleeding and pain. And then report any temperature elevation. We're also monitoring for infection, just like any other surgery. And the after pressure dressing removed, provider may order wound care and topical medications until the area is actually healed. And then approximately 1 month after the inoculation, a prosthesis can be fitted by an optician. And that is chapter 59.